We did case study 20 and it's trichotillomania. In the case study, it was about a girl named Suzanne. She was very nervous all the time about school. Her parents always wanted her to be better, and she was very pressured. She didn't feel like she was going to get into a good college. She started plucking her eyelashes out, and she would feel better when she did that, and she was less stressed. Her parents finally realized that she was picking her eyelashes out, and they like freaked out at her. So she ended up stopping doing that. She got accepted into college, where she met some guy named John who lived like right next door to her. They dated, and when they broke up, that's when she started pulling out her actual hair, and she ended up becoming depressed because they ended up breaking up. Her mom saw her hair and freaked out again, and she told her mom she was going to just start therapy. She started therapy, and eventually she stopped pulling her hair out, and now she has a new boyfriend.
So the diagnostic criteria from the DSM-5 for trichotillomania includes recurrent pulling out of one's hair resulting in hair loss, B. Repeated attempts to decrease or to stop hair pulling, C. The hair pulling causes clinically significant distress or impairment in social, occupational, or other important areas of functioning, D. The hair pulling or hair loss is not attributable to another medical condition, and E. The hair pulling is not better explained by the symptoms of another mental disorder.
So Suzanne meets the DSM-5 criteria as Suzanne pulled out all of her eyelashes when she was in 7th grade. She pulled hair from her scalp freshman year of college, resulting in a bald spot on the right side of her head. She failed at her attempts to try to stop pulling her hair from her scalp, even though it caused bald spots and embarrassed her. Suzanne didn't try to date in college because she was embarrassed by her bald spots, and there were no other medical conditions mentioned in Suzanne's case.
So other possible comorbid diagnosis for Suzanne would be depression, because after her boyfriend John broke up with her, she couldn't sleep. At some point she had insomnia, and she also had a lack of interest in things that used to interest her, like she was failing her 2 classes, and she had feelings of worthlessness because her parents put so much pressure on her. She didn't feel like she was ever good enough. And the other possible comorbid diagnosis is social anxiety, because her parents criticized her. They would ask her why she isn't good enough. They say that like she could have done better. She was insecure, and she would often feel embarrassed, especially when she had the bald spot on her head from trichotillomania.
Another diagnosis considered, we thought OCD could have been one. Similarities would be hair pulling in trichotillomania is comparable to compulsive behaviors in OCD. Hair pulling behaviors is involuntary and serves no other purpose besides providing temporary relief. The contrast would be compulsive behaviors in OCDs are done in response to an obsession. Compulsions are done in a realistic way in an attempt to prevent something bad from happening.
So another diagnosis that we considered for Suzanne was borderline personality disorder, because she had insecure attachment to her parents, and her severe trichotillomania started after a breakup, and she has a history of unstable relationships. It was mentioned in the case study that she had trouble creating relationships with friends and with boys in middle school. Also, Suzanne idealized John, and Suzanne lacked coping skills. She engaged in self-mutilating behavior by pulling her hair out, and she had an unstable sense of self because she latched on to John in college. She felt insecure about her ability to take care of herself, so she just really latched on to him, which showed that she didn't really have a stable sense of self.
For our treatment goals, for our intermediate, short-term, and long-term, for immediate, we want her to recognize when she's pulling her hair out or about to pull her hair out, and take stock of emotion and triggers when she's pulling out her hair. For short term, we want to eliminate some stressors that are in her life, and so she can work on her coping skills in order to deal with some of the stress and emotional aspects of her life. And for long term, being able to deal with stress on a daily basis with school and her parents, and being able to overcome the temptation to pull out her hair.
So treatments that we considered for Suzanne include cognitive behavioral therapy, because this would involve exposing her to stimuli that causes stress or that's upsetting for her. For example, we would have her record a situation comparable to what happened with her and John with the breakup, and have her listen to it repeatedly until she doesn't find it stressful or it doesn't provoke anxiety for her. And also with having her self-monitor to record how stressful a situation is, how many times she pulls her hair out, and help her find an activity to help her cope with not pulling her hair out, and to instead do something else, like something involving self-care, like going for a run or taking a bath. Another treatment we considered was habit reversal training, and this type of therapy has been heavily researched. It's very promising for people with trichotillomania. It includes behavioral techniques by increasing the awareness of the undesired behavior, and the focus of this therapy is to teach coping skills and to keep the patient motivated to continue progress. And another treatment is medication, because if talk therapy doesn't work or she needs additional help, medications like antidepressants might be beneficial, especially medications that work with serotonin have been found to be beneficial for trichotillomania. And psychotherapy, because if she does have depression, she might need additional psychotherapy to address depression.
For her treatments continued, how long do you think your client will need to remain in treatment? She will end up being in treatment for about a year or longer if needed, but after the last session, we will have a catch-up every 3 to 6 months to see how she is coping with stress and emotions. For habit reversal training, it will be completed in about a month. This training only addresses reduction of hair pulling behavior, and a lot of the times clients will actually shave off their hair in order for them to stop pulling out their hair, so that could be another treatment if all else doesn't fail.
So why did we create the treatment plan? Since she was feeling stressed and emotional when she started pulling her hair out, either due to her parents or John breaking up with her, we focused on how to deal with these events that may take place in her life so she could better understand how to cope with them, so that she's not turning to pulling her hair as a way to coping. If we have her record the stressful situations and listen to them, she'll become less stressed when she hears them, and the more exposure that she has, the more she gets used to it. It doesn't affect her as much. So also having her write down when she feels these emotions in these situations, when she pulls her hair out, this will help her avoid the situation altogether, or help her know that she may have to deal with these stressful events. And also, what obstacles do you think you and your client will face during the course of treatment? The client might have difficulty tracking when she's pulling her hair, because she does it fairly often, and a lot of the times she's not aware that she's doing it. And also, tracking a behavior that you do often while you're under stress can be just difficult in general. And since her parents weren't very supportive to begin with, she might have trouble finding a good support when stressful things do come up. And if something stressful occurs during the beginning of treatment, she might not know how to deal with it right away. So that could increase the hair pulling behavior before we're able to address it. And this is our references.